Good morning, everyone. Dr. Bhavana Prasad, consultant neuropsychiatrist and also a child psychiatrist from Bangalore. And before I start my session, I would like to thank Dr. Sushmita Madam and Dr. Basan sir for giving me this opportunity. I consider this as my privilege. And why psychiatrist in this session? What is the need for my session is mainly, you know that there is so much of load of cancer in India, and also a lot of pediatric surgical load is there. And parents and children go through a lot of stress. So as pediatric surgeons or pediatric surgical oncologists, how can you spend some time in your OPDs and your routine so that you can assess the level of anxiety in children who are above 4 or 5 years and also in parents, and then refer them. And as it goes with today's theme, early detection and early referral. So that is the whole reason for this topic. How to change the slide? Amit. This is some of the statistics. According to WHO, approximately 3 lakh children between 0 to 14 years are diagnosed with cancer each year. And they represent only 2% of all the cancers, even though the leading cause of children between age 1 to 14 years is cancer. And these are some of the common cancers. And also, because there are a lot of pediatric surgeons here, there are 2% of babies born with congenital defect every year. Among that, 0.1% requires an urgent surgical intervention. So this shows there is a huge load of pediatric surgeries. Now, when do you expect that these children or the parents undergo anxiety is, especially when it comes to the cancer related cases? It could be at the time of the diagnosis where you're going to tell them about the diagnosis, or anytime during the course of the treatment, or sometimes even after the recovery. So it is not that only in the beginning you should do the counseling. It is throughout the process till the recover, and sometimes even after the recovery, there is a lot of anxiety. And especially children with inadequate family support and poor temperament suffer more than what is expected. And here I would like to stress on 2 points. It is not just the case, or it is not just the few set of children or diagnosed who undergo anxiety. It mainly depends upon the person's personality, parents' personality. And in children, we don't use the word personality, we use the word temperament. So sometimes you come across parents who would show more anxiety, they might be asking more questions, or you might come across the children or adolescents who throw a lot of temper tantrums, not very cooperative for the procedures. So you need to understand it is not that the child is very arrogant or rude, it is because of the underlying anxiety. So also the same goes with the parents. And also there are certain families with poor coping skills that may suffer a lot. And when it comes to the statistics of how much percentage, around 75% of children and also the parents experience pre-operative anxiety. And when I mention anxiety, it is not just the worrisome they have, it is a clinically diagnosable anxiety and depression. And around 58% can have symptom of depression, 23% can have post-traumatic stress disorder. And also you need to understand that whenever they have parental anxiety, that even going to affect the child's anxiety. This is a particular study which tells about the amount of parents undergoing anxiety in the children with congenital diaphragmatic hernia. And there is an interesting finding in this study where they show that even the gender difference can be seen. That means the anxiety is more among mother compared to father. And when you know, I mean, why do you even consider this counseling in these cases? Is there are a lot of factors which are contributing to anxiety in parents. One, like most of the factors are known to all of you, like parental separation, leaving a child, 1 day or 2 day child just for 5 hours or 2 hours is a very difficult task for any of mother or the father. But now you take the child inside the OT or any procedures. So there is some amount of parental separation, lack of control over what is going to happen. You don't know the prognosis. You don't know how the surgery is going to happen. And definitely during your counseling sessions, also you explain parents about the complications. So that also can lead to, and parental gender, as I just mentioned, that mother show more anxiety compared to fathers, and fear of post-operative pain, age of the child. This is very interesting that as the age progresses, the parents expressing anxiety also increases. So you need to know that a parent coming with 1 day old child, if you compare a parent coming with 10-year-old or 15-year-old child, the anxiety is more with the parents who are having older children than 1 or 2 days. That is basically because of the less bonding they share with the child. And also fear of financial losses they are going to go through. And other family members might be at home, elderly parents are at home, or another child has to attend the school. There are a lot of factors which is going to get disturbed. And also post-operative pain and future of the child, like how much he is going to recover, whether he can attend the school, for how long he is going to be off from the school, and nowadays parents have a lot of dream. It's not just related to the academics, sometimes even the sports or any other activities. So they are concerned about the future and the child's disability. And definitely my husband was just showing me a picture of a child with lot of scars on the abdomen. So definitely fear of cosmetic issues of the child. So these are all the factors which can lead. And before this, I also want to tell you that, as I mentioned in the beginning of my talk itself, not every child is same, not every parent is same, and not all the cases you can expect the same amount of anxiety. So it is the person's personality, parent's personality, or the child's temperament, which is ultimately going to define. You might think that, why is this patient annoying so much? Why is this parent not understanding? I have explained 100 times. No, it is because the person's anxiety. So what can you all do in your initial evaluation is, you need to assess the child's pre-morbid development, how was the temperament, and psychological history, functioning, and this all I think you all anyway do it, genetic disorder, significant life event, if the child has undergone any kind of trauma, sexual abuse, and how is the educational attainment and academic strength. That gives you some idea of how is the cognitive ability of a child, how much the child can understand. The more intelligent, the more cognitive ability, the child is going to express more anxiety. And when it comes to parents, you need to assess their personality, their life events. And if a parent is already having any of the psychiatric disorders, then the challenge is more. And how is the family functioning, social support, which all contribute to number of anxiety. So now I am going to introduce few of the screening tools which can be used in your OPDs or their clinical setup. And quickly you can assess the level of anxiety. These are all with high validity and are easily available and can be converted into the local language also. So there is revised child anxiety and depression scale, pediatric symptom checklist, brief psychiatric rating scale for children, and impact of event scale. As such, only for specifically for preoperative anxiety, I could find only one scale. But let me again tell you that these scales can be applied only if the child is at least 3 years and above. Less than that, you cannot apply, you cannot assess the anxiety of a child. So I am going to share the PDF later of this scale, which I think you can use it. Pediatric symptom checklist. This will be filled by parent, not the child. And it is going to cover both physical and psychological well-being of the child. And now in the similar way, we have certain screening tools for parents as well. As I mentioned, during their waiting area, whenever they are sitting and waiting for the procedures, anytime you can ask your trained nurse or anyone to just give them these scales. This is one which I'm showing is hospital anxiety and depression care, which covers both anxiety and depression in the person. These are very simple questions which will be answered. And if in your OPD or in your department, if you come across any parent having score more than 10, that means that this person is not having just normal anxiety or worrisome about the surgery. That could be handled by you, but definitely this person should be referred to a mental health professionals. So now, once you know the factors causing anxiety, now you know why, how the personality and temperament plays a role in person's anxiety. Now you know. Now, what we do post-treatment evaluation is, for children, there are a lot of things like impact of physical sequelae if patient has lost any of his functioning, treatment received so far, educational engagement, how much he has been able to cope up, whether he has gone back to school, how much is functioning, and cognitive problems. Sometimes they can have poor attention because of the underlying anxiety and psychological symptoms. And for parents, you need to assess the family functioning, whether they've been able to cope up with their financial problems or any other issues. Parenting style. Post-operatively, you can see different type of parenting style. Some can become overprotective, over-anxious. Even though you have told the parent that a patient is absolutely doing well, child is fine, he can go back to school, he can do all the activities, but still parents are not sending. Or sometimes they can become too critical with the child, or sometimes if they are coming from a poor socioeconomic status or a father with more of a narcissistic personality, then they can start blaming the child. Because of you, I've lost so much of money. Because of you, I've lost my job. So these kind of critical comments can also happen. All these things will be assessed, and current social circumstances where they're living, and also again, as I told, psychological symptoms. Now you have assessed all these. Now you can consider a medical term for the anxiety, what they're going through. There is something called as pediatric medical traumatic stress, like how we call it as PTSD. This is the set of psychological and physiological response of the child or the family to any of the pain, injury, illness, medical procedures which they express. So more like they have all the anxiety symptoms, panic symptoms. And I am going to here highlight on few symptoms which you can yourself as the parent. Very important, as we all know that biological functioning is very, very important. You can just ask the parent, how is your sleep and appetite? These two are very important biological functions when it comes to mental health. Anybody, if they say consistently for more than 2 weeks, they're having disturbed sleep or any kind of change in their appetite or decreased concentration. And also sometimes you can observe their behavior towards you. If they are becoming more irritable, getting angry, or asking too many questions, that itself give you a hint that this person is going through some psychological issue and he needs a help. And now another entity which we diagnose is adjustment disorder, where parents of children with cancer or any of the major surgeries may experience enormous physical and emotional pressure. Children and teens, definitely when they come to adolescent about 10 years, they are going to have all the cognitive ability. So they also undergo a lot of adjustment. And now there is an important term here, illness cognition. So you might have diagnosed 3 kids with the same illness, same cancer, with same prognosis, but not all the 3 kids and the 3 parents are going to respond in the same way. What is that then differing is the illness cognition, means how much they have understood, and also not just understanding in the terms of understanding about the prognosis and all, but whether they are more positive about it or whether they are more negative about it. Some parents can have only negative cognition, where even after telling 10 times that the prognosis is good, they are going to believe that, no, maybe I'm going to lose the child, maybe the child is going to die. Or sometimes you have explained everything and told that the prognosis is bad, then they might have a pseudo cognition. So what is more important is what the parent or the child feel about the illness. And all of the any anxiety related disorders can be seen, which can manifest at any stage of the treatment. As I told you, it can be at the time of diagnosis, during the course of treatment, and sometimes many years even after the child has recovered. It is often intense at the beginning, but can at times be expressed as a refusal of treatment or procedures in the beginning. And there is a specific anxiety called procedural anxiety, which is for procedures. So it can be as simple as taking a blood test, pricking nails, or any kind of invasive procedures, or as such taking the kid for CT, MRI. Many a times we get a lot of calls that child is not cooperative for MRI, child is not just listening. So there is definitely, that is called procedural anxiety. So these are the common psychiatric illness reported in the parents of cancer or any major pediatric surgeries. As I mentioned, procedural anxiety, illness-related anxiety or illness anxiety disorder, where they have the specific anxiety related to, they might go through a lot of research. And if you are seeing a patient coming from upper socioeconomics, educated, they will a lot of Google search about the surgery, procedures, complications, everything. And whole day, they'll be only thinking or talking about the illness. Panic disorder, where they get intense fear, can have all kind of somatic symptoms like palpitations, sweating, tremors. Insomnia, nightmares or night terrors common in children. And sometimes you can see what is called as secondary nocturnal aneurisms. Primary means from the birth itself, child has never had a control over the bladder. But secondary means sometimes after a severe trauma or any major event, that in a child which had stopped doing the not having aneurysms at time, now it has started again. So this can be seen. Generalized anxiety disorder, mixed anxiety and depression, major depressive and post-traumatic stress disorder. Now, what do we do as a psychiatrist, child psychiatrist or a gender psychiatrist? How are we going to intervene whenever there is a... So we have non-pharmacological and pharmacological intervention. In majority of the cases, 80 to 90% of the cases, we are going to consider only non-pharmacological intervention, because already child might be receiving chemotherapy, might be going through a lot of other drugs. We don't want unnecessary medications or complications. And also this can be handled well with non-pharmacological. So parental counseling is what is considered here. The definition of counseling is there, but what you need to understand is parental counseling in continuum. So most of the time I've seen surgeons, pediatric surgeons doing counseling before the surgery. You definitely do it. You take a lot of time and explain them about the procedure, but that itself is not should not end there itself. It has to continue throughout the process, throughout how many times the patient comes for follow-up. Every time, make sure how much ever you are busy, you might be having a lot of surgeries next in a queue, but make sure that the child and the parent receive a proper counseling every time they make a visit. So preoperative anxiety intervention, there are a lot, which you consider it as preoperative education. And I am sure that most of you are all from the central institution, so definitely you all follow protocol. But I have seen in peripheries where they just do the counseling over the phone call. You come tomorrow with 6 hours of fasting and then you come and get admitted, we'll operate on you. So that kind of counseling should not happen. It should be a proper face-to-face counseling in a dedicated area where there is no much of noise, no much of disturbance. You can use paper-based methods, or you can use audio visual. As I mentioned, the children, if they are above 6 years, 7 years, you can show them animated video. Adolescents, you can explain them then what exactly you're going to do, what is the procedure, what is anesthesia, what are you going to do it. So take some time, and the parent might ask multiple questions, they might have multiple doubts. But if you want to get that complete trust of the parent throughout the your journey, then this is where you need to hold them. The first few sessions, parental counseling sessions, which you do should be very well done. And these are the components which should be included. Accuracy, tell them exactly what your medical knowledge says. Then it should not be like beating around the bush. Be specific and tell them what exactly is it. Show some empathy, because I think as a pediatric surgeon, you all have that. So make the parent realize that you understand what they're feeling. Reproducibility and cohesive means if you have a team, you have a junior surgeon, you have a senior surgeon, you have an anesthetist, you have a surgeon, nurse. If you have a team, each and every person should give the same information. One has said the prognosis is good, some other doctor will come and take the rounds and they might say that, I don't know, maybe. So be specific, and all of you should give them the same information. Suppose if there is a bereavement, if the baby has, there is a death of a child, something has gone wrong, then the whole bereavement team, which includes psychologists and social workers, should come. And the therapy, if suppose you have done a screening, you have assessed and you have felt that the child or a parent is having more anxiety, so what exactly we as a psychiatrist do is, we include certain psychological therapies, and especially for child, we cannot do any cognitive related therapies. What we do is more of behavioral therapy. We teach them how to control their anxiety. To begin with, we make the child understand that it is okay what you're going through, because many a times they're not coming and expressing that I'm feeling anxious like others. They just throw tantrums. They are very irritable. They might be more demanding these days. So this is how we pick up that the child is having anxiety, and we take them for behavioral therapy. And for adolescent, definitely they are very good cognitive development is there. We can take them for therapies. Keeping thought diaries, we teach them. Guided imaginary, like, if you're taken for surgery, imagine that, you're not in a OT, you are somewhere else. Positive self-talk. I'm not going much because that is our job. This is again mindfulness-based therapy and progressive muscle relaxation therapies. And these are actually not a very difficult ones. Some of person in the department, if you don't have a proper psychiatry setup, a nurse can also teach these relaxation techniques. Play therapy. And in this play therapy, not just the child, even the parent is involved, and we teach them how to ease, how to go about the surgery. Music therapy is nowadays the latest development. And if I have to tell about the pharmacological treatment, as I mentioned in the beginning, we usually avoid till a child is showing a severe anxiety or the depression symptoms. Suppose there is especially the biological symptoms. There is very much deprivement of the sleep, or child is not at all eating, not sleeping, or showing severe panic attacks. Then we consider the safest drugs, which are selective serotonin reuptake inhibitors, SSRIs, like for example, escitalopram, fluoxetine, sertraline. These are some of the drugs which are very safe. And most of the time, SSRIs do not have any major drug interactions with any of the chemotherapy agents or any other drugs which you are using. And also when we give a minimum possible dose for minimum duration. Meanwhile, we also take up the child and the parent for therapies. So most of the time, we avoid pharmacotherapy for minimum period at minimum dose. And this I have already mentioned. So sometimes you can also use only benzodiazepines, like if the child is not having major anxiety or depression, but only comes up with panic attacks just before the surgery. Panic attack is showing anxiety symptoms just before the procedures. Then you can use, especially you can use short-acting benzodiazepines, because that will not have major later effect. And coming to, so now this is all overall what you can do at your setups and how we can go about. So taking simple measures like giving a very good preoperative counseling, taking time in explaining them, listening, assessing their personality, the temperament of the child, and simple tips like reduction in the number of OPD visits. If you call the child, they might have come from very far places, as many as procedures, what and all you can do, finish off in one visit. Extension of free of charge category, involvement of NGOs, which I'm sure most of the institutions have. Parents of patients suffering from complex congenital anomalies should be referred to a clinical psychologist. So this I've seen in many institutions where I was working in St. John's, where they regularly send the child to child guidance clinic for the preoperative counseling, and periodic counseling sessions should be conducted. So to conclude, as today's this conference theme itself says, early detection and early referral. So what I would like to stress as a child psychiatrist here is, as a pediatric surgeon, you might be following the protocol of preoperative counseling, but also include certain screening tools and also involve the parents or other family members. And if at all any time during your process you come across anybody having more of anxiety and depression, kindly refer them, because how the controlling anxiety or depression is going to anyway affect the course of the illness is definitely, if a parent is having so much of anxiety, it is affecting the child's health also. So, and also sometimes the productivity, their financial income has come down because of their anxiety. So in overall development, you are going to help them, and that would ultimately indirectly affect the prognosis of the child also. So screening tools can be used. Referral to psychiatrists or psychologists should be done for early diagnosis and management. Child psychology should be included in the team. Adapting integrative preoperative preparation program can significantly reduce the parental anxiety. And periodic counseling and regular follow-up visits are to be done in case of children with any chronic illness. So this is how what I wanted to stress on, that there is a high prevalence, around 75% of anxiety and depression among parents, and also the children, especially adolescents. And using simple screening tools, you can detect them at early stage and refer them for the management. So I really thank Dr. Sushmita Madam and Dr. Basant sir for giving this opportunity. And with this, I conclude my session. Thank you.